We are so glad to have you here this evening. We are going to have a very distinguished panel. It's an exciting event to have. We welcome those of you that are here live and also our friends on Facebook Live for this important discussion. We're going to talk about transforming maternal continuum of care, both locally, statewide, and nationally. We'll take a close look at key aspects of optimal prenatal care, intrapartum care, which is care in the hospital, postpartum care, and also the care that we give to that infant, that newborn infant, through its first year of life. That's very important. The skilled professionals that you have here this evening will cover that wide range of that continuum of care, with emphasis on today's challenges, while we are trying our best to assure equitable, accessible, and high-quality treatment for all women, and particularly for women of color. As Doug and Dave mentioned, I'm Gus Parker, and I serve on the Health Justice Committee for the Reimagining America Project here in Charlotte, North Carolina. And again, I'm going to serve as your moderator, and what an awesome panel we have here and an awesome challenge I've been presented with. But we will get through this, and hopefully we'll learn a lot and as we move forward. I'm going to get us started. I'm going to call to give us a brief words, and I'm going to look to Ms. Jennifer Roberts, who is one of the co-founders of RAP, and also a former mayor of Charlotte, and also Reverend Claude Forehand, to come forward and give us a few words, if you would. While they're coming to the stage, maybe they'll say this, but RAP is a nonpartisan organization that got started in 2020, I believe, and in the wake of the tragic loss of life of George Floyd in this country. So again.
Absolutely. And thank you. You caught me with granola bar. But they're good snacks. I want to welcome everyone. This is also my church, Caldwell Presbyterian. And we want more community events to happen in this hall. It's very environmentally friendly. We believe in diversity and inclusion, justice and equity, and we want to see more of this happen. I know there are folks who are going to be watching this online later. But I am one of the co-founders of the Reimagining America Project. Claude is our executive director, and Rodney Sadler is the other founder, who unfortunately is not here yet. We hope he's on his way. He and I met in the streets the first night of the George Floyd protests, and we walked together and we talked about how we have to change America. And we also talked about how racial justice is tied into every single subject and aspect of our lives that you can think of. It is baked into our systems. It is up to us to change that narrative, to change the systems. It takes time. This is not a sprint. This is a marathon. This is our lives. It's our futures. It's our children's futures and our grandchildren. It's the future of our country. It takes all of us. And so I am really pleased to see this meeting tonight to talk about this very important issue. It's very central to all that we're trying to do to raise awareness, and then to come up with solutions that we can all message and talk about and advocate for. Because these disparities are not right. They're not just. They've been going on for way too long, and people who look like me need to be allies and be part of the solutions. And now I'm going to let Claude say the amazing work that he's doing as well.
Thank you, Your Honor. I want to also say welcome. Thank you for coming. Thank you to this esteemed panel who's before us. The Reimagining America Project is an organization that is focused on calling out racial disparity and oppression that is found, like Mayor Roberts was saying, that's found within our systems. Our role, our chief objective, our attempt is to at least bring awareness to it with evidence-backed research to show how this is existing within our local and regional areas. This is just one of the various events that RAC is aspiring to coming together to bring more insight and awareness to the existence of racialized oppression. And I'm thankful because this is a topic that's often not talked about and is often overlooked. And so we're hoping that as you all are watching, whether by television, whether by Zoom, or you are here today, that we continue to talk about this issue, acknowledge it, and bring it out even after this event, because it still consists, or it is still going on. So this is just one of many that we're trying to do for Reimagining America Project. And again, thank you for coming and looking forward to hearing what these wonderful panelists have to say.
Thank you both. Thank you. I want to say that the purpose of tonight's program represents a wonderful collaboration with the League of Women Voters of Charlotte Mecklenburg County, the Coalition for Truth and Reconciliation, and the Healthcare Justice of North Carolina. This is a very important and timely topic as we've discussed, maternal morbidity and mortality. We'll be spending tonight, this is part of a 2-night series. Tonight we will focus on delving into the disparities, race disparities, and seeking to highlight bright spots, because there have been some work and improvements that have been done in maternal health care, but also where we can focus on what we can do now. Part 2 of our series will focus on more of getting to the work of what we can do in terms of policy, legislation, advocacy, directed towards sustainable change. Sometimes we talk about things that we can do in the immediate aftermath of some of these events, but we want sustainable change that needs to be systematic, both locally, statewide, and nationally. So for that, I thank you for that. A few ground rules before we get started, and I got to do that myself. I'd like for everybody, certainly here present, to silence their phones if they want. So I'm going to do that so I'm not guilty. And also, Dr. Keeley, Dave Keeley, will serve as our timekeeper, so he'll let our panelists know if we're getting short on time, and keep your answers concise if you would. And we're going to give everybody equal time to have an opportunity to address these questions. As some of the prepared questions are posed to you, I may pick on certain ones of you as I know your area of expertise, but I would encourage you all to, and I'll give you that opportunity to jump in as well for those questions. Also, we would encourage those of you in the audience that are in attendance to use the index cards on your table. Those will be collected and forwarded as we have time after our panelists have had an opportunity to speak. We'll be able to take some of your questions from the audience. Those of you that are on Facebook Live, put your questions in the chat, and certainly we'll be able to mine those and hopefully give an opportunity for response to those as well. So at this time, I have the distinct honor to introduce our panelists. And I'm going to start with Dr. Janisha Brown here to my left. We'll go this way. Dr. Janisha Brown is a family medicine hospitalist and member with Atrium Health, Wake Forest School of Medicine. She's a founder and executive director of Birthright Incorporated, a nonprofit organization focused on ending Black maternal health crisis through community education, advocacy, and the like. And I think she'll be able to personalize a story for us as she has an opportunity to speak this very, very powerfully. Next to her is Dr. Pam Cobb. She's a board-certified obstetrician gynecologist with a focus on serving underserved populations. She's a medical director for Atrium North Park, co-chair of Atrium Health's Women's Health Maternal Disparities Committee, whose goal is to narrow the gap in perinatal outcomes for women of color. She is a Speak Up Against Racism champion through the Institute for Perinatal Quality Improvement. Dr. Pam Cobb. Next to her, Venus Standard. Venus is a nurse, midwife, and doula. She is assistant professor at the University of North Carolina School of Medicine, Department of Family Medicine, and Women's Health and Maternal Child Care. Let's see, next to her is Melissa. Okay. Melissa is one of our doulas. Melissa is a DONA certified labor support doula. And for those of you that are unaware about DONA, DONA was originally founded as the Doulas of North America. Doulas of North America, that's what DONA stands for. I had to refresh my memory on that. But Melissa is a DONA certified labor support doula. She currently is engaged in DONA's postpartum and Lamaze childbirth education programs. Her passion and calling is supporting Black Generation Z teens as they transition to becoming parents. Next to her is Erica Wynn. Erica Wynn is also, she serves as a nationally registered, she has served as a nationally registered EMT, emergency medical technician, in low-income communities. She too has become a certified doula and labor support doula. As she strives to create a positive birthing experience, she is seeking certification as a board-certified lactation consultant. Is that correct? And next to her is Taisha McLean, Ty McLean, right? Is that okay? Ty McLean. She's a director of lactation, board-certified lactation consultant, and member of core team at Queen City Cocoa Beans, a nonprofit lactation organization. She's the program director also for the lactation training program at Johnson C. Smith University. And next to her is Tiffany Bishop, and also her partner in crime, Whitney Cable, if I may. They are perinatal mental health providers. They are founders of Raising Resilience, a maternal mental wellness business dedicated to educating the Black community and fostering resilient families. Tiffany is a licensed mental health counselor specializing in Black maternal mental health, offering support for women facing challenges in parenthood, fertility, and perinatal mood disorders. Certified in trauma-focused CBT, cognitive behavioral therapy. And next to Tiffany is Whitney. Last but not least, Whitney. Whitney also focuses on empowering everyday women to cope with life's challenges. She's a certified in perinatal mental health, birth trauma, also that CBT and perinatal EMDR, which is eye movement desensitization and reprocessing therapy. Is that right? That's a mouthful. All right, would you please welcome our esteemed panel? Thank you. So I have the privilege of challenging with some of our initial questions. So bear with me here. But this first question, I'm going to say that we talked about the continuum of prenatal care, intrapartum care, and postpartum care. And so I'm going to throw this at Dr. Cobb. And oftentimes, we have been fighting in this battle of maternal morbidity for many, many years. And I'd say that it's almost like the definition of insanity. It's doing the same thing over and over again and expecting a different outcome. So what we're doing is clearly not working. We haven't had great improvement in that regard. So the question that we have for Dr. Cobb this evening as an OBGYN, do you see the value in non-traditional ways to deliver prenatal care more effectively? Why aren't provider institutions and practices adopting some of these innovations? And how would you suggest we engage pregnant women in this space? That's a lot, but you're up to it. Here you go.
Can you hear me now? Yes? Perfect. I think that the question stems from initially what is failing in our conventional prenatal care, or how can it be improved? When you look at Black women seeking prenatal care in Mecklenburg County, they actually seek care in the first trimester about average, which is about 60%. So lower than white counterparts, more earlier than Hispanic Latinx. But when you look at Mecklenburg County's data with regard to infant mortality and maternal morbidities, they far outweigh in terms of poorer outcomes for their pregnancies and their infants. So if they're seeking care about average, what is wrong theoretically with the care that they seek? And what I would say, by virtue, if you've ever had a baby, and I'm seeing someone having a baby there, we know that if you've ever had a baby, conventional care is fast, limited, and does not meet the needs often of Black women. So you're pregnant for 40 weeks, but you might see your provider for a total of 3 hours. So that's a little bit of a disparity there, of course. The other thing about prenatal care is it tends to be a little bit more like a revolving door, meaning that what should be a 15-minute visit often is curtailed down to about 7 minutes in the door to make sure everything's okay, and then you're out the door. Again, it is the nature of the beast often with fee-for-service. So how can prenatal care be improved? We know that the way that prenatal care right now is being delivered does nothing to address the racial biases for Black women. It lacks in the ability to be patient-centered and relationship-centered. One of the things that's happening, particularly in the US, that is different than in other industrialized, richer countries, is that we're a little bit upside down. Most of our care is provided by obstetricians, gynecologists, who are trained to diagnose abnormalities and to intervene. And you can see how that perhaps in a normal physiologic pregnancy can be a bit desensitizing, where all you're doing is doing the next test and the next test and the next test, and it does not promote a clinician-patient relationship. What I would say is that when you look at a 7-minute visit with 3 hours over 40 weeks, there is most definitely in that 7 minutes a power dynamic, right? There is a physician or another provider saying, do this, take this medicine. There's some implicit power inequity with regard to let me be seen, let you recognize who I am, where I came from, and what is important to me. So one of the things that is the love of my career is bringing centering pregnancy to Atrium in Mecklenburg County. And for those of you who don't know what centering pregnancy is, centering pregnancy is a model of group prenatal care, where women, instead of being seen individually by one provider, are seen by one provider over the course of the entire pregnancy, but they do that matched with other women in similar gestational ages who are seen with a curriculum of information and connectivity. What centering pregnancy does is takes women out of the exam room and puts you in a community of women that can give you support, you can share experiences, you can be seen, and that very important relationship that is not fostered with conventional care is now promoted, and there's a connection with perhaps your nurse practitioner or your midwife or your physician over the course of the entire pregnancy. Interestingly enough, centering pregnancy has been around for many, many years and now has randomized trials that support it decreasing preterm labor, decreasing small for gestational infants, particularly in Black women, promoting longer breastfeeding, and essentially improving not only the experience of the pregnancy and delivery for the patient, but also for the provider. So to me, it's an absolute win-win. It is healthcare looking at the value of the person, value of the patient, as opposed to a more fee-for-service, time-based compensation.
Thank you. That was excellent. The I wanted to mention that when you talked about centering pregnancies, oftentimes those occur in the community, in community resource centers, and closer to where patients may live and where that group of women have synergy relative to that community. Is that correct?
That's absolutely correct. One of the things that I think is the reason that the outcomes are improved is that when you go to where folks are and take your care out of the healthcare system and move into the community, people surround themselves with family. And so it's much more of an organic, sustainable, nurturing environment to have a child.
Thank you for that. I want to move on to one of the things that you highlight is that we traditionally have OBGYN providers, but we have all other providers, some of which are represented here. And this question is for Venus, our certified nurse midwife and doula. If you would, why is having providers, office staff, and assistants in the medical office, why is it important that they be representative of the patient population we're serving? And how do you think that impacts the ability to reduce maternal mortality and morbidity?
Thank you. I think it's extremely important to have people caring for you.
If I may, I just want to stop you for a second. Why don't you tell us a little bit about your role as a midwife and doing how that's different from traditional OBGYN providers? I think that's important on the top end of this question.
As a certified nurse midwife, I care for women and birthing people in the continuum of their pregnancy life, or in their continuum of their ability to have children. So from early teens on to menopause. We can actually have care from that beyond to elder care. I choose to limit mine to the childbearing age. We do a variety of different things. The one thing that we do not do is direct surgery. We do assist. Once you get your basic certification and license in midwifery, you can get all extra certifications. Like I'm trained to do first assist, so I can assist with a C-section. Some of my colleagues can do circumcision. Some of my colleagues do a variety of different things. It depends on what you want to focus on after you get your core level of training. But we are there with women and birthing people throughout their GYN life, throughout their women's care, throughout their pregnancy, at the delivery, and then beyond in the postpartum period as well.
So I preface that because I wanted everyone to understand the role of all these different providers and how they're part of the team. Getting back to the providers in the office setting, your assistants, why is it important that we have providers that reflect the community we serve? You know, we say that African Americans are about 13% of the population, but we only have about 4% that are physicians, and probably less that are representative of doulas and midwives and that sort of thing. So would you comment on that?
Yes, I think it's extremely important to have a team that looks like the community that you serve. It makes people feel more comfortable. It's a lived experience situation. They come in, they see somebody that could have the same experience that they did. They may have the same family structure that they did. They think that we get the trust card by default, right? Because they trust us. There's a large disconnect between the Black community trust level to the medical community because of historical trauma. So we get the trust card by default to, oh, you may understand what I'm going through. You definitely probably have experienced some racism or some disparities or some people not listening to you. You may have experienced that, where a provider that doesn't look like you may not. Having the level of inclusion is very important. You have a person with a different culture, maybe have a different religion, maybe have all these different things that they bring to the table that could also influence their outcome. So a provider that may not look like them may not understand to ask certain things or to expect certain things, or to know generationally, grandma is going to expect this, or grandma told you that, or you may have a religious thing that requires, that may have a different outcome of your experience. And it's not always looked at it. And like Dr. Cobb said, when you're this 7 minutes, 8 minutes, you don't have time to explore all of those nuances that somebody may bring to the table. And people bring all sort of things with them that can influence their healthcare.
Yeah, you spoke of racism, and also I wanted to ask, you talk about majority providers and providers that do reflect the communities they serve. Do you think it's important that providers should have to undergo annual implicit racial bias training and other educational components?
Oh yeah, yeah, and I don't think it's a one and done thing. You can't do it and check a box, okay, I'm good. It's an ongoing thing. It should be interwoven into everything that's done, because if you have a patient that comes in and is of a different culture, is of a different religion from you, and you took that course 4 years ago, you may not remember some things that's very important to her or to that person or to their family. But I think sitting and being in a racial equity type training is extremely important, not just once a year, because we're used to doing things once a year that we have to do for these extra, requirements. I think it should be done multiple times a year, 2-3 times a year, so this way it's not forgotten and almost a task, like, oh God, I gotta take that training again. It should be often, so now it's woven into everything that we do on a daily basis. Because if we're caring for people of all different cultures and all different races, you can't just have a one-time training once a year.
Yeah, and make no mistake about it, all of us need that type of training.
Yes.
We need it through the entire cascade of our healthcare system.
Yes.
We need our people that serve on admissions committees to medical school and nursing schools to have that same kind of training when they're choosing who gets admitted and those sorts of things. So thank you for that.
Yes.
Thank you for that. I'm going to take a little time to direct the next question to Dr. Janisha Brown here. She's a family medicine physician. I want to remind you of that. But we talk about maternal toxic zones, or areas where people live and work, and how that has an impact. Certainly we talk about the social determinants of healthcare. Would you speak a little bit on the impact that environment has and that is brought to bear on women that are seeking healthcare?
Oh, absolutely. So outside of pregnancy, honestly, where you live significantly impacts your health outcomes. It's one of the largest social determinants of health in regards to how things go for you as an individual. And when you're talking about maternal health, you want to think about access in regards to being able to see a provider. We've already talked about whether that provider shares the same cultural beliefs as you or can understand them in a way to be able to meet you where you're at. But also outside of that, just being able to get the foods you need to have a healthy pregnancy, being able to get the transportation that you need. What does that look like for you to get to see a provider, to get to a hospital when you're ready to deliver? Even outside of that, we were actually having a conversation before this about how we don't think about all the other levels of exposure that individuals go through based upon where they live and what they are taking into their home and using for their own health. One of the things that I explored today in another area was about how Black women hair products have a huge impact on health outcomes, and how some products that they widely market in Black hair care shops and in the convenience stores we go to, the pharmacies we go to, how those products have different chemicals in them that can be hormone inducing and can lead to some of these common medical conditions that we see in pregnancy, like preeclampsia, gestational diabetes, or even preterm birth. So when you're looking at, you're talking about these maternal toxic zones, there are neighborhoods where women are having decreased access, having issues with finding healthy foods, but then also outside of that, the exposures of daily living. What are they using for their bodies? What's in the air? What's in their home that's coming through the vents? All these things matter when you're trying to have a healthy birth.
Thank you for that, Dr. Brown, I know that we applaud your efforts and your interest in working on particularly Black infant mortality and maternal mortality. But you also have a unique perspective by your own personal journey, your own personal story. If you don't mind, would you be so kind as to share that with us?
Yes, absolutely.
We'll take liberty at time to do that.
Well, it's always a benefit to be able to share my story so that it can raise awareness for other Black women who are going through what I went through and also who go through more than what I went through. So my second son is 6 years old now, but 10 days after I had him, I was just sitting in my home entertaining, a well-wisher, like we do, when you have a baby. And I started to feel this very strange pressure-like sensation in my chest. Normal pregnancy, very healthy my whole life, everything was fine. Took all my prenatal vitamins and took all my prenatal visits, sitting there, not doing anything, actually just, having a conversation. This strange pressure sensation just would not go away. That sensation developed into uncontrollable vomiting, shortness of breath, and by the time I got to the emergency room, I knew something was going on, but by the time I got to the emergency room, I had 10 out of 10 ripping chest pain. That would be later diagnosed that night as having a heart attack. And I say later because it wasn't before. I was actually almost misdiagnosed and sent home. The provider that was seeing me that day said that maybe I was having a panic attack, or maybe I was having, heartburn related to pregnancy. And this is even as I'm describing to him this feeling of like doom and, that my heart is flipping in my chest. And what ended up saving me that night was actually, when you are in the emergency room, providers know that if a patient comes in with chest pain, you have to recycle their blood work before you discharge them, even if you feel like nothing is wrong. And my blood work was recycled, and my heart labs came back severely abnormal through the roof. So diagnosed with a heart attack from a condition called spontaneous coronary artery dissection, which means that one of your blood vessels in your heart has torn and is leaking and is starving, the rest of your heart, causing a heart attack. So I was almost one of these women who, out of the 1,200 women who die in America related to pregnancy, I'm one of the Black women who was 3 times more likely, who was almost 3 times more likely to die related to pregnancy. And so when you're thinking about that statistic, these are women who are carrying, women who are in labor, or women who are in the postpartum period, like I was, which is that 12-month period after you deliver. 1,200 people in America, in this rich resource country, die every year from a normal process of pregnancy. And that number might seem small to some, but when you think about it on a granular level, that's somebody's mother, that's a newborn that will never meet their mother. That is a wife, that's a sister, that's a friend, that's a daughter. And so compared to other rich resource countries, we have the worst maternal health outcomes in this country. Not even talking about morbidity, which is hard.
Yeah, thank you for that powerful testimony. I want to say that when we talk about maternal morbidity and mortality, a lot of these deaths, if you will, are considered preventable. The majority of them are considered preventable. And we often talk about women of color not being seen or heard by their providers. Women, men, when something's not right with your body, the way you're feeling. But getting that provider, whoever they may be, to listen to you at whatever level, whether it's the nurse midwife, the person at the bedside, the physician assistant, or the nurse, the physician, someone needs to be aware of these statistics through these educational processes and have their antenna on high alert. But we've got to dispel a lot of these myths about how Black people perceive pain and their emotional components and get through that process so that we don't have these tragic outcomes. Thank you for that testimony. I next want to move to Ty McLean. And if you would, Ty is a lactation consultant. I want to remind you about that. And this question came up. Statistics have shown that Black mothers are not breastfeeding in the numbers comparable to their white counterparts. Can you speak to the benefits of breastfeeding and why it's important to have a lactation consultant as part of the maternal health care team?
Okay, yes. So yes, as a lactation consultant, we all know there are great benefits to breastfeeding. It is the recommended diet for a newborn infant. Why? Because breast milk is gentle for babies to digest. It's easier for them to process. And for moms, it also has great benefits. In the Black community, we talk a lot about the breastfeeding benefits because, one, it's free. All right, we love free. But then it also decreases the rates of SIDS. It helps decrease the rate of heart disease, of type 2 diabetes, breast cancer, any other reproductive cancers. These things plague the Black community. So with breastfeeding and starting out with, we like to say a good foot or a good start to life is going to help reduce those things. And then with moms, we tell moms that, you know, it's going to help you lose that pregnancy weight. A lot of moms like to hear that, as well as one of the things I always like to mention about breastfeeding, besides the free aspect of it, is the fact that if we had moms breastfeeding in this country, we would save $300 billion in health care, and because it extends beyond just infancy. So this, as children continue to grow and they were breastfed, we recommend for at least 6 months. And then now it is to provide breast milk until the age of 2. I personally breastfed both of my kids, one for 1 year, until they were 1 year, and the other one until they were over 2 years old. And so they have decreased earaches. They have, they're not really sick that often. We don't have to deal with a lot of allergies. So those are a lot of the benefits that come with that. But a person that has never seen anyone breastfeed, I was one of the first people in my family to actually breastfeed. So not to be able to see that in your community and not know where to go to for help is what led me on the journey to become an IBCLC. And so with that role, it's important to have me a part of your care team because just because breastfeeding is natural, many women feel like it's gonna be easy. And it's not. I say if that was the case, I would eat healthy all the time, and I don't. So for that, you need support. It's very, very challenging because you don't know what to expect. You don't know, if my baby is getting fed enough. You don't know what to look for if my baby's having enough wet and dirty diapers. You don't know, if the color of that baby's poopy diapers. That means a lot in lactation. So to have me a part of your care team is just to say, hey, things are going well. We hit a little road bump. This is how we can redirect the course until we can get back to breastfeeding. So it's very important just to have someone that's knowledgeable about breastfeeding to kind of help you through those things because most people give up in the first 2 weeks. And so by people giving up in the first 2 weeks, I'm here to kind of help get you through those first 2 weeks and hopefully to 3 months and then hopefully to 6 months, hopefully to a year. And then especially in the Black community, and I experienced this myself, if you breastfeed after that baby's a year old, people start to look at you a little different. And so they wonder, why are you still breastfeeding that baby? But there's still a lot of benefits to providing breast milk after babies are a year old. And so just to help people understand that breastfeeding is an evolution and it changes as babies grow and how it should look. So it's really one of those things I like to say that I'm an adult cheerleader. So I am there to support moms, I'm there to cheer them on, I'm there to give them the knowledge and information that they don't have, especially in the Black community. When I was breastfeeding, I didn't know where to go for help to get a lot of my answers. And when I started doing my own research, I felt really lost, and I went to some organizations and I was like, they don't look like me, they're not talking my same language, we don't have the same lifestyle, where are my people? So with that, I started to reach out and I started to find help and I started to connect with moms that look like me. And then that's how myself and some other ladies, we developed Queen City Cocoa Beans, which is a nonprofit here in Charlotte to help support our moms. And then that led to the Johnson C. Smith program because we need more lactation consultants that look like.
Well, you answered the second part of my question, which is, do we need to clone you? Or in the wide spectrum of lactation consultants, do you have a percentage of how many, what percent of women, African American women or women of color are lactation consultants?
So they don't keep records, but if you're a Black lactation consultant right here in the Charlotte area, we know each other. And when I became a lactation consultant, I was one of 3. I serve in different areas, and I'm always the only lactation consultant of color wherever I go. But through certain initiatives, we have changed some of that, especially with our Johnson C. Smith program. We have graduated at least 13 women of color that are now lactation consultants here in the Charlotte area.
Thank you, fantastic. That's great news. The next, I want to move to our perinatal mental health professionals, and that's Whitney Cable and Tiffany Bishop. And I have a question, I'll pitch it to both of you. What is the biggest misconception you think people have about maternal mental health and maternal mental health providers?
What I'll say is the biggest misconception, and I think it's like twofold. One is really what maternal mental health is and how common those challenges are. And so like a little perspective, I would say that at least 1 in 3 Black women will experience a perinatal anxiety disorder. And so a lot of times because we don't look at it as so common, there's like a lot of blame and shame from the birthing parent who's experiencing those challenges that comes with that. And then another part of that misconception is that a lot of times we don't hear about everything that maternal mental health kind of like encompasses. We only really hear postpartum depression. And so that really puts mothers and birthing people at a disadvantage because there are so many more challenges and disorders that one can experience. And when you're experiencing these complications or these symptoms associated with like maternal mental health challenges, and it doesn't necessarily fall into this box of what everyone has like deemed as postpartum depression, it leaves you feeling like confused and unseen and isolated and like this. A lot of times what Black women will say is like, I'm just not good at this, right? I'm not good at being a mother, I am failing. But really it's like, no, our community just isn't educated on all of the maternal mental health challenges that comes with pregnancy and beyond, right? Like when we say that it's more than just postpartum depression, the correct term is perinatal mood and anxiety disorder. And perinatal in itself means during pregnancy and the postpartum period. So that means that I can experience any mood disorders or implications while I'm pregnant or even after I have a baby, right? And so also there's this misconception of like postpartum depression that means that I want to harm myself or my baby, right? And that in itself, that still keeps women from receiving the necessary care and support and treatment that they need. Because that's not what maternal mental health or perinatal mood and anxiety is in itself, right? Like we have, for me, with my first daughter who is 6, I was a therapist for a while before I had her, and all I knew was postpartum depression. And so, I remember talking to Vivian, like, I'm not sad. Like, I don't feel sad. I'm angry, right? Like, I feel irritable. I can't sleep at night. Like, I'm always worried about what's going on. And then, like, after training and getting different certifications, it's oh, what I was experiencing was postpartum anxiety. And honestly, I had like anxiety while I was pregnant too, right? And so these challenges that we experience can happen during pregnancy, postpartum. It's not just depression that we need to be looking for. There's perinatal anxiety, there's OCD, there's bipolar disorder that can occur in pregnancy and postpartum. And most times when women are diagnosed with bipolar for the first time is after they've had a child, right? And then we also have postpartum psychosis, and that is what the media kind of like takes and makes a big deal about. Oh, if you're experiencing postpartum depression, this is what it looked like. But postpartum depression and postpartum psychosis are two totally different things, right? They're both important. One varies in its severity and intensity, but it's not the same thing. And we need to be able to like educate our community, our parents, families, providers, to let them know that this is not what it looks like, and we need to be honest and truthful about what this does, because the shame and guilt and the stigma around it really keeps women from seeking out the care that can really like shift their whole perspective and parenting journey.
Thank you for that. One of the things I want to ask you, your organization is an independent practice. How do you partner with referrals, be it from hospitals or OBGYN practices or others? Where is that connection?
So we get referrals from OBGYNs, lactation specialists. We do a lot of events in the community. We started off before we became a full-blown mental health practice. We were, still are a nonprofit, so we do like a lot of community events, collaborating with others in the community. And so we get our referrals from people who have, or providers and community members who have direct contact with these families and with these mothers, right? Like our doulas, midwives. So I hope I answered the question.
Yeah, that was fun. I think one of the things that I noticed in your bios is that you focus primarily on women of color. And Whitney, it's not just women, it's couples. It's both the parents involved in the care that you offer. What can parents expect to get from the services you provide?
I think first is to address, we always get a lot of questions about why we specifically put an emphasis on working with Black mothers and couples. It is a question that comes up often. It is a question that we get from referrals. And I think when people see maternal mental health, it does impact all women, but there's a special emphasis when it comes to Black women. As you heard all of these very talented women here on the panel, there's a reason why there needs to be an emphasis on Black women and couples when it comes to maternal mental health. Your mental health impacts everything you do. Who you seek out for a provider, how you feel when you go into a provider, even how you feel when you come into me and Tiffany. What are your things that are already resonating in your brain? I think for me, and I'll say for Tiffany, we do a lot of residual work with the women we serve. A lot of the women that we see, we're processing things that they may have felt with a provider 2 or 3 years ago that was never addressed mentally, and having to go back through why they may be feeling nervous about even going through with a pregnancy this time, because they may have felt silence. They may have felt like, well, if I said something, I may feel like I'm non-compliant. I may feel like, one of my clients, one of the things that we've really been working on, and she always lets me share, is her NICU experience. No one even asked how she felt, and we're just now processing that. Her son is 6, and we're processing how it felt to walk from the NICU, from the maternity unit every day, and she was still trying to breastfeed, and she was still trying to pump, and her child is hooked up to all of these machines. And so we're just now processing it 6 years later, because no one ever asked to say, how are you feeling mentally? How do you feel physically? That is a big thing that me and Tiffany asked, because when we think about perinatal mental health, it shows up differently for Black women. How we describe it, it may be, I'm just tired. Me and Tiffany know what that I'm just tired means, versus a provider that may not see that emphasis or just that intersectionality of Black maternal mental health and mental health. We know what I'm tired means. I'm gonna ask more questions. Does that mean you feel stressed? Does that mean you feel like you have no support? Does that mean, was it hard to even just show up today? I go a little bit deeper with it. I also think understanding that more physical symptoms are described for our clients that we work with. It may be, hey, my stomach feels funny. Most people will overlook that and just say, oh, that's part of your postpartum recovery. Me and Tiffany may be able to look and say, oh, they're having some GI issues, the stomach is feeling weird. That may be, postpartum anxiety. That may be anxiety they're having. One of my clients was having a pain in her side. We ended up finding out it was something completely different due to her stress. So I think me and Tiffany understand for our clients the physical implications and also how much your mental health impacts those, how it shows up for you. I think another thing with couples, I work with a lot of couples where we're working in that pregnancy period and talking about some of the challenges they're already thinking about going into their birth plan or the birthing experience, and having to talk with some partners and dads about how to advocate if something goes wrong. And I hate that, but due to the statistics, we have to have some of those real conversations. And I hate that we have to have that, but me and Tiffany get a lot of couples that say, I don't want her to die. And I hate that Black women are constantly told this narrative of, I hope I don't die, I don't want to die. But mentally, we are faced with so much fear going into pregnancy and the postpartum period, and even possibly dying in the postpartum period. So I think me and Tiffany put that emphasis there for couples, partners, support people, for them to know, hey, if you notice your partner is being a little isolated, if you notice your partner is a little bit irritable, if you notice that they're having trouble pumping or breastfeeding, how do you address that and have that conversation with them? How do you already have a maternal mental health therapist already kind of like in your pocket? Because when you're in crisis, it's hard to know where to go. You don't know where to go when you're in crisis. So that's why we put that emphasis, and that's kind of the experience we give our clients.
Thank you for that. That sounds like a service that's sorely needed, and we appreciate you being in that space. One of the things, we've got two newly minted doulas with us this evening, and I'm going to toss this to Melissa, if you would. There's a lot of mystery, I think, sometimes with people as far as what doulas do or what the scope of their practice is. Would you mind sharing with us a little bit about what doulas are engaged in terms of perinatal health care?
So as doulas, we are trained professionals to support moms during the labor and delivery process, emotionally and spiritually. So with that comes with a level of transparency that we're able to show them, and we build trust with the moms. And once we build trust with them, we're able to educate them. We're able to educate them on certain important keys that they need when they go into the labor and delivery room. Certain keys are BRAIN, that's an acronym. It stands for asking what's the benefit. When the doctors come in and they ask them or they try to give medical interventions, we tell our moms, you can advocate for yourself. Ask what the benefits are. You can ask them, what are the risks? If I decided not to do it, what are the risks? We teach our moms that you can ask for alternatives. You don't always have to go with the very first option. Ask what are the alternatives. And then next, follow your intuition. As women, as Black women, we have that intuition. So at the end of the day, follow your intuition. And lastly, you can tell them no, not at this time. So that's what BRAIN stands for. It stands for benefits, risk. It stands for alternatives, intuition, and just saying no, give me some time. That was the major thing as a doula that I've been able to provide to my clients. It's just educating them, giving them the confidence to ask questions in the labor and delivery room.
Thank you. I know that my experience, my experience tells me that the role of doulas has grown over the years. And certainly there's a lot of information and studies well proven that the use of doulas in the perinatal and an intrapartum period lower C-section rates. It also increases mother's well-being mentally during the course of their labor and delivery, and is a wonderful experience for most of the mothers that engage in that. That being said, I know it's been challenging over the years for doulas to be able to have access to patients because of misconceptions. I know it's been challenging to get access to hospitals. So Erica, what are some of the challenges that doulas face in engaging women, particularly women of color, to provide the services that you have?
Okay. So, as our role as a doula, we spend this time with our clients, about 3 to 6 months before they go into that delivery room. And so this time we spent, as Melissa said, educating them, supporting them mentally, physically, emotionally. And so we're getting excited for this birth. And so, when I get that call, it's time to go to the hospital to deliver. We're excited. And so when we get to the hospital, the challenges that I face, that I think is the most obvious challenges, we're met with pushback from the nursing staff or just the hospital staff in general. They treat us as if we are not a part of the care team. And so that poses challenges as where I'm trying to support my client. They see that we're getting pushback and it hinders us from further assisting the client. And so, I have to take the time to talk with the care team to let them know that we are all a part of the same team, we have the same goal, and that's to have a positive birth experience and to have a healthy mom and healthy baby. Some of the other challenges, specifically in the triad area, most doulas are charged to actually come into the hospital to deliver these services. And so, that could pose a problem where maybe that doula doesn't have the funds to assist the client at the hospital. In the triangle area, they also have to have contracts they have to sign in order to come into the hospital to support their clients. And so those are some of the challenges that we face.
Yes, thank you for that answer. A follow-up to the question I asked before, how would women go about obtaining your services?
Well, most recently, a lot of my clients that I've met or that I've had work with in the past, it's through the LEAD program. So Venus has this LEAD program. It stands for Lived Experience Accessible Doulas. So this program is actually fully funded. We're able to provide doula services to our Black moms at no cost. So that's how a lot of my clients have been able to reach me lately. My goal is to actually work underneath my own entity, to have services that I can provide to my moms. And for that, I'm not sure how they're able to
Are doulas, are some of them partnering with traditional OBGYN practices to provide services or employed by hospitals?
Well, actually, something big that's going on right now in the United States is certain companies like Microsoft, Walmart, and CVS, they're providing doula services for their employees. So that's something that a lot of employers are realizing, that their employees, they need access to doulas because of all the research that's going on right now in the United States. So that's really great. A lot of employers need to get on the ball with that as well.
Fantastic. Venus, did you want to add some comments to that?
Unfortunately, some areas do have payers, insurance companies, and Medicaid that's covering doula services. Right now in our area, that's lacking. United Healthcare actually pulled the trigger a few months ago and decided to pay for doula services for their Medicaid population. We have spoken to other payers as well to try to get them, but it's not widespread. So right now it's still a fee for service. The clients have to pay for the service for doulas, and in our area, the average doula cost is about $1,200 to $1,500 right now, and that's sometimes unreachable for some families. If you have other children to feed, rent to pay, and $5 a gallon gas to put in your car, that may not be feasible to be able to pay $1,200 for a doula. And it's unfortunate because the people that need it the most are the ones that often can't afford to pay for the doula service.
Yeah, we've highlighted the importance of this whole provider panel as being part of the care team. So certainly we got to get this right and figure out a way to get those services paid for and covered by insurance. At this time, I'm going to throw out a question that has come up, and bear with me, I'm gonna read a little bit, and then I'm gonna throw it out to the entire panel, anyone that wants to address this. For Black women, it is hypothesized that the accumulation of racial stress, so-called weathering, contributes to the disparity in morbidity and mortality rates for mothers and infants. It is said that the stresses of living in a race-conscious society that stigmatizes and disadvantages people of color are chronic and persistent throughout the lifespan, taking a significant toll on the body of Black mothers. Young Black women are, in fact, more likely to have poor pregnancy outcomes if they are in their mid-20s than if they are in their late teens, the exact opposite outcome of their white counterparts. It's been postulated that Black women who wait a few more years to have a baby suffer poorer outcomes because their bodies are more weathered and biologically older than their actual age. How does that theory correlate with what you see in everyday practice caring for Black mothers? We'll start with Janisha, and maybe we'll just pass it on down.
Well, you know, I speak a lot about this because I definitely think it was a part of my story. So some of it I own because, you know, as first generation, a lot of things in my family. I had a lot of high goals. I had opportunities to take breaks and didn't take them. You know, I wanted to push through. I wanted to do this and do that, you know, because of some of the signals that you get as being a Black woman and also because of what you put on yourself. So there's definitely a conversation internally about taking those breaks and being kind to yourself, loving yourself, because sometimes we don't get those signals as we grow in the Black culture. And maybe that's just me, but that was something I had to come to terms with and own for myself as a part of that conversation. But I think outside of that, you know, when you're talking about weathering, and I know you guys want to talk about it too, but you know, it's just, you know, this constant almost like chipping away. When we think about that rock that's on the edge of the ocean and those waves are just crashing up, you know, that ecological kind of view of how that continues to change the exterior surface of that rock. You know, if you can imagine what that would look like for the body, you know, my heart being primed, you know, when it's been under stress before and now it has all this stress and now it's ready to break, right? Because of this constant kind of like beating from the things that you experience in society, the things that you experience as you're trying to reach your goals to have a better life for yourself and your family, how those things really impact you and prime you in some way, form, or fashion to have these negative outcomes when you're now under a stressful health event, which is pregnancy. Your body is being challenged. So there's a lot of conversation I have with Black women before you are pregnant. You know, start taking those breaks, being kind to yourself, speaking kind words to yourself, understanding that you are not a superwoman and that everything that you put into your life, you know, that requires strength, it's coming from somewhere. And you have to take a pause to put that back in, or you will be in a depleted state. And like I said, prime for some of these negative health outcomes that can occur in pregnancy.
You mentioned Superwoman. A colleague of mine, Dr. Cheryl Woods-Kiscombe, has coined Superwoman schema. And basically, that's where everything to everybody, and we always put ourselves last. And like you said, we have to take time to care for ourselves, because if you can't care for yourself, you can't care for anybody else, including the person that you just grew inside of you, right? So we have to remember, take time for ourselves.
So there's a book that we reference a lot in the mental health world called Body Keeps the Score. I'm also reading this book called My Grandmother's Hands, and it's kind of like a more look into like racial inequality and trauma, and then how that plays on our body and how we keep the score. And a lot of times what Winnie and I talk to our clients about is that these traumatic events, right, like your body is holding on to it. whether we realize it or not, whether it's consciously or subconsciously, it's kind of these traumatic events, these racial injustices, not even like the things that we might endure personally, but just vicariously, like watching Black men and women die on the news, on the TV screen, right? Like there's so many medias like at our fingertips, and we open our phone and it's like trauma right there. And so how we describe it to our clients is like, if you think about those traumatic events like being made into buttons, like they're buttons inside of you, and then when another traumatic event or something that feels familiar, that button is being pressed, and your body is having a biological or physiological response to that. And this is why we are so tired. This is why we're exhausted. This is why we don't feel well. This is why our stomach is upset, right? Because our body is keeping score. Those things, those experiences are within us. They're now embedded in us. And then it's like the buttons just keep being pressed and keep being pressed over and over again. And that not only has implications on our physical health, but our mental health as well.
Thank you for that. Dr. Kopp, I think you wanted to say something.
I think it's been said exceptionally well. The only clarification that I would say is that we all know, I mean, I didn't come through medical school knowing this, but genetically, that genetically we are, 99.98% all the same. So the concept of Black people and white people, Black people being genetically incapable of carrying a pregnancy to term or incapable of delivering a full-term baby, that is not true. And so one of the things that I think that we have to retrain our minds to say is when a woman comes in, or I'm talking to a medical student and they say to me, if a Black woman gets pregnant, she is at higher risk for preterm labor. That may in fact be true, but that's looking at her Blackness as the risk. What we need to say is the life experience of this Black person when she becomes pregnant, her life experience puts her at risk for delivering this baby early and this baby to being born early and all those repercussions. We need to retrain our minds to understand that the lived experience is what is tied to outcomes. How people are seen and how people see themselves.
Thank you for that. Yes.
I also wanted to add to that. I've also heard too this saying that it's not our Blackness that's a risk factor, it's the system that's our risk factor.
Yes, often we hear that comment that with everything being level, age and risk factors and all that Black women suffer much more terribly, and even in comparison, education. It's often by the majority of the population thought that just by the nature of the color of our skin, that Black women are more at risk. But we have women that are highly educated and in great shape, have taken care of themselves and done everything possible on their end to have a healthy pregnancy, and yet we suffer terribly 2.5 to 3 times greater risk of maternal mortality compared to our white counterparts. And to that end, there must be these other factors in play, be it physiologic, stress-related, and some of the things that you've mentioned this evening. So thank you for those comments. As we've been mining the chat and some of the questions, I'm going to try and get to as many of those as I can without screwing it up. Thank you. And the first question, hopefully I can read Dr. Robinson's writing. This is such an important discussion which expands into menopause and the type of care women receive at the next phase of their life. Will this type of discussion expand into menopausal stages? And maybe I'll address our mental health professionals. I think, again, my experience tells me that medical education is getting better at some of these topics, but there's still a long way to go in being sensitive to some of the changes that women experience during that phase of their life. So would either one of you like to address that? Yeah, the question is, in this discussion, will we talk about the next phase of life with expansion into the menopause?
You know, I mean, and for in the mental health perspective, because I mean, we focus on the postpartum period, which never really ends, right? But our mental health, like our specialty, focuses on the dynamic of the transition into becoming a mom, right? Like in parenthood and beyond.
Okay. Dr. Cobb, would you like to comment?
Okay. I actually am not a menopausal expert, but what I do know is that in general, culturally, Black women transition into menopause and have different symptomatology by virtue of whatever reason than white women do. That in general, my white patients often will come in and say, "Woo, give me the estrogen, give me the hot flash drugs, give me the," and my Black patients want to think more holistically about treating estrogen. Is this something I can do with diet? Is this something that soy can play a role in? Is this, and one is not more valid than the other. Certainly, menopausal symptoms can be treated with diet and exercise and behavior modifications and all these things, and we have to, as practitioners, be willing to think that that is as equal and as valuable. And so what happens is we get, again, a shifting of that power dynamic when we just want to just write the script. Just write the script and you're done. No, let's talk about it. Let's think about what's going on in your life. Where is your stress level? What is exacerbating? Are you getting enough sleep? All of these things change your menopausal symptomatology.
Dr. Brown.
Even as a family medicine physician, you know, extend that conversation to understanding, like you all were discussing, the things that you have seen happen in other family members, and understanding even the increased rate of having poor prognosis from certain cancers and things like that that occur in the Black community. You know, some Black women might choose, I want to go the natural route because I saw what happened to so-and-so, and that didn't end well for me, so I'm going to suffer through this, you know, and I think that really cycles a lot of things that we're talking about here, about how, you know, having somebody like a Dr. Cobb to have that conversation with you, that you believe that she has an understanding of what happens culturally in our society with Black women, understanding that increased risk and how you can have that conversation with her on a different level and say, do you really think this is safe for me? You know, okay, I don't want to suffer through this, you know, but I also don't want this to happen. How can I protect myself and still be kind to myself? I think that is definitely something that is a conversation that needs to, you know, you need to have room with to be able to have with your patients because of those images that we have seen and those worsening like health disparities outside of just, you know, the pregnancy time that we see for Black women in the Black culture in general.
Yeah, thank you. Several of us are involved in medical education or have been, and I think it's important to bolster that and say that there have been changes in that. I know when I had to self-educate about more naturalistic approaches and holistic approaches to medications and herbals and things like that. I think good medical professionals are not threatened by a questioning patient. I think you have to have a questioning attitude and be your own best advocate when you have that doctor-patient relationship. That's a whole nother discussion. But I think that we're doing a better job in terms of medical education in bringing that discussion in early about alternative medicines and alternative holistic approach to how we engage patients and gain their trust with these differing opportunities for care. I'm gonna move on to the next question. First, this person says, I wish I had a doula. You guys are awesome. And there are some things a married husband just doesn't know or understand. I know there's a question in here somewhere. Working with families, how do interracial couples factor into your work? Are there particular needs?
Well, in my experience, because I was specifically trained for, sorry guys. So I was specifically trained for Black women. That's what the LEAD program is for. Again, stated lived experience successful doulas, because that's where the problem is in America. That's where the greatest problem is in America. So yes, while all moms are dying at a higher rate than any other industrialized country, the U.S. has a problem with the maternal death rate, but more of a problem with our Black moms. So I have not got the experience, but I look forward to it because all moms need doulas, right? But I look forward to the experience, but my experience is only for our Black moms right now.
In our program, we have so far supported 300, and I believe our last count was maybe 34 families, 34, 35 families. And of that group, there's only been 2 interracial couples. And there was no difference in caring, specifically because the bias comes from her perspective, right? If he wasn't there, she would have been treated the same. If he was there, she would have been treated the same because it's based on her. We've had it the other way around where a family has called, same way, but the family has called and said, my husband is white, can I still have a doula? Yes, you can, because you're Black, baby. Yeah, you can. So there's no difference in how they're trained to care for the families, and there's no difference in the care that they receive.
Any other comments? The next question states, understanding that Black mothers are more likely to suffer the worst outcomes of pregnancy, what role can the birth partner play in promoting a healthy and successful labor and postpartum period?
I think it's first important for the birthing family to understand that they're in it together. I think that the mother or other people in the healthcare team expects for that man not to be a part of the birthing experience. And so myself as a doula, when I do reach out to my clients and I support them and educate them on what childbirth experiences are like, I make sure that that man is there to support the mother physically and emotionally.
All right, very good, very good. This is kind of directed toward Venus Stanley. And how does races and cultural sensitivity factor into medical school training? Is it getting better?
In medical school training, I don't know directly. I haven't gone through medical school. I went through midwifery school, which was a little different, right? We only focused on OBGYN in our training. From what I may gather from working with our residents team, I'm gonna go with it and say not necessarily better. Better, but not better, right? Not optimal where it should be. But I'm going to let Dr. Cobb, who has gone through medical school, and you.
So for the new Charlotte campus for Wake Forest, I'm actually the director for a curriculum that addresses inclusion, diversity, equity, advocacy, leadership, and social justice. So it's IDEALS is the acronym. Also combined with a portion of medical school training called health system science, which is understanding how to work in teams, which needs to happen in healthcare. So we've been building this curriculum for maybe the past 2 years or so. It is very innovative in medicine. So, I mean, I think that I will say, which is very inspiring, is that it is something that medical students, a lot of medical students want. I think post a lot of the issues that we had in 2019 with the racial reckoning, with George Floyd, the murder of George Floyd, and the similarities that everyone went through with COVID in general, really opened a lot of people's eyes to the more that needs to be a part of healthcare systems to really be able to address health. And so that is very inspiring, and it's been great to be able to, talk about bringing in community partners to educate students, using, diverse faculty members to speak on experiences, bringing in patients to talk about their own experiences with, discrimination and bias and, all those other, isms that happen to us in medicine that really lead to differing health outcomes. So it is something that's happening. Wake Forest is definitely not the only school that's doing it, but I would say it's definitely a more innovative space, and prayerfully it makes a difference soon.
Yeah, I'll briefly comment on that as well. I had the privilege to be involved with the faculty for the branch campus at UNC Chapel Hill here with Novant on the Novant campus. And I think the students are getting more of health equity training from day one. And through programs such as this and speakers that we bring in, our campus had a focus on health equity. And the preceptors that we engaged in medical education, we stressed the importance of making sure that that was infused in every aspect of their clinical years and resources that they brought to bear in educating students. And we had a feedback loop relative to that to get feedback from the students as to how that was going. And so we're still in the early phase of that, but I think one of the good outcomes of the tragic loss of George Floyd was that we hypersensitized institutions and people to do something. And maybe that doing something may have bear fruit. We may not see it immediately, but hopefully it will start to affect a change in how we structure medical education for our students, medical students, residents, and our current physicians for workforce.
Can I comment on that as well?
Please.
I was doing a talk, I guess about a year ago in Chicago, and it was a family medicine conference, and there was about 150 family medicine physicians in the room. And when I pulled up a slide from a survey that the NIH had put together about, I think, 2016, and it was based on general population, it was a series of questions, general population, first, second, third year residents, and then first, second, third year residents. And it was questions like, do black people have more? The questions. So it was about 20 different questions, but some of them were, do black people have thicker skin? Do black people feel pain more? Are black people's brains smaller? It was this whole series of questions, and the way they were answered as a first, second, and third year resident, you saw, yes, the trend maybe went down a little bit, but the numbers were still extremely high. No, black people don't feel pain. Yes, black people's skin is thicker. Yes, their brains are smaller. They bleed less. They, like it was this whole series of questions. It was very disheartening. And actually, I showed the article or the survey on the screen, and this one physician challenged me and said that has to be 20, 30 years old. So I had to show him that was only like 4 or 5 years old, and this is an active survey. And then after the talk, 3 or 4 physicians came up to me and said, we're sorry, we were just not taught this in school. We were not. So I'm happy to hear that things are swinging to change, because if you're going to support and care for a population that doesn't look like it, you can't think that my skin is thicker and that I don't feel pain.
Yes, we have many programs that are promoting our youth to engage or consider a career in health professions, because we need people of color represented through every aspect of medical education, residency, hospital, physicians, nurses, midwives, doulas, as well as hospital administrators. And if we don't, then we're going to not see those changes take place. So it's a systematic change we need to see throughout healthcare. Because when we talk about healthcare racism, we're talking about a system, not just individual people. So we've got to change the system. Next question. Physicians have traditionally resisted or use of physician extenders, if you will, like midwives, doula, etc. Do you see movement to acceptance and support? Is this acceptance greater among Black MDs and providers? Go for it, Pam.
I don't know. I think that when you talk about a Black woman engaging the health system has to do what is necessary for patients coming into their purview to feel the most comfortable and to be the most seen and have the most cultural congruency. So, in my mind, it is a good investment to have not necessarily OBGYNs who are trained to cut, but to have more midwives and more nurse practitioners and more physician extenders. By virtue of them having more time, by virtue of them being a little bit less, I don't know what the word is, outcome test focused and a little bit more relationship focused. So in my mind, it's an absolutely good investment. I think that's just a dollars and cents and an outcome. I don't think that has anything to do with Black physicians being more open to it than white physicians. I just think it's a smart move for a healthcare system.
Hopefully, as the general public becomes more aware of the benefits of physician extenders, if you will, nurse midwives, doulas, lactation consultants, and the like, that as people see the value in that, they will push for more access, for more engagement of those. And sometimes it becomes a marketing ploy for hospitals to say, yes, we're on the cutting edge of what's best in healthcare. And so hopefully they'll push hospital systems to see this as a benefit that they can market and advertise to gain more market share, if you will, to bring people to their hospital for that type of care. So in my mind, if hospitals take advantage of the skill set that we have here and promote that, it may give them better access, and also as we extend that, to get things covered by insurance, and it would be a win-win for both. When we talk about that win-win for both, I think providers are under tremendous pressure, particularly when they work for hospital systems as compared to being independent practitioners. I'll pose a question to the whole panel, but do you think that productivity models that physicians and providers, nurse practitioners, nurse midwives are under to grind out and get those patients through the system because they're on a time, and you know that they get 11 minutes and 37 seconds before they're supposed to see the next patient? If they're not being that productive for them, then they may not be as valuable as a practitioner that's pushing patients through the system. But we all know when you talk about that doctor-patient relationship, you can't establish that if you don't have time. So I think it's a double-edged sword and very challenging for providers to adhere to that productivity model and to be expected to give that same level of care and understanding and establish the element of trust. The element of trust is so important in that provider-patient relationship. Would any of you like to comment?
I'll comment on that, and as well as piggyback on the last question. When it comes to lactation consultants, I see that a lot of physicians, a lot of hospitals are reaching out to lactation consultants because they realize that they don't necessarily have the education to be able to support moms. Most physicians, maybe I've heard the last time, maybe get about 2 hours of information and educational lactation. So they don't really understand the mechanics of it. So to have a person that's specialized specifically in lactation is an asset for them. Because like you said, they don't have to spend all of that time explaining colostrum. They don't have to explain transitional milk, engorgement. They don't have to explain these things. And sometimes they don't even have the knowledge to explain them. They don't have the right verbiage to use to let moms know. A lot of times we hear, especially for a lot of the women of color, they say, oh, your milk hasn't come in. So moms think, oh, I don't have milk to feed my baby. They don't take the time to let them know, no, your milk is going to transition to mature milk. So we have to go through this transitional period. So you have milk to feed your baby, but we're gonna get to mature milk, right? And what that looks like for them. So it's an asset to have a lactation consultant. And so they're reaching out to us, and so you're gonna find us now in more physician offices, OBGYN offices, in the hospitals. But it's very, very important when I walk into a room, and even in the NICU, I did some time in the NICU, when I see those moms and they're able to see me, their eyes bright up, because they're like, oh, this person is gonna be able to relate to me and be able to explain it in a language that I understand.
Thank you. Any other comments in that regard? It's down here.
I think a big thing is reimbursement. A lot of the times, I think in the mental health world, we're not always reimbursed for the work that we do. And I do think oftentimes for Black providers, we have to make sure we're not burning out our Black providers when it goes from medical, mental health, because a lot is put on our back to serve Black women, couples, but we want to make sure we're not burning out our Black providers. And that they can show up as their best self. So I feel like that productivity pushes when you're able to get clients in and out. But I have clients that will talk, and I know sometimes I have to be able to say, hey, I'm gonna need to have a diagnosis for this client because they have to use Medicaid, they have to use insurance. So I do think a lot of times that productivity is pushed often by reimbursement. Am I gonna be able to bill for this? Do I have time? Can I meet with this client and give them the time that they need? And also, one thing that I see is a lot of our clients need to be connected with other resources. They don't come in and just need one thing. I might have to connect them with Ty. I might have to connect them with a pelvic floor specialist. So I do feel like that need for reimbursement and productivity, and to see so many people when you're a Black provider is such a need, is that high demand. So I do think it impacts us, but I also don't want Black providers to become burnt out because so much weighs on their shoulders to provide unique and culturally aware service to clients.
Yeah, thank you for that. You made me think of another question, and that is, I know we all have a lot on our wish list, particularly when it comes to how we could impact reducing Black maternal mortality. If I could grant you that one wish, what one thing would you want to change or would request in the system that would help improve or reduce Black maternal mortality? We'll start down here. Janisha? Yeah, just one. We only have time for one from each of you. I know there's a lot on the list.
Yeah, that's a really good question. I say this, but I do have a disclaimer because I do believe that increasing diversity in the healthcare workforce will really be an important foundational backbone for changes in healthcare for Black persons, all persons. But I think the thing that's important to understand for people is that being Black is not a monolith. And so just because someone has Black skin, it does not mean that they understand culturally, where a woman comes from completely, or understands, the nuances of this or that, or even that they can relate and talk to the person in a language that, culturally, hits with them. And so I say that because I do think it's important, and I do think you would catch a lot more providers who could stand in that space for Black women and persons. But I think it really comes with the understanding that that can't be it, because they're just like, everybody else, everyone is an individual, and if you increase the number, you will increase the amount of people that are similar, but it's not just about skin color.
Thank you. Dr. Cobb?
It's a hard one. I think that even as a physician, I remember going to my kid's pediatrician appointment, and I was in there for longer than 7 minutes, and by the time I got out to my car, I couldn't remember what they said to me. I mean, I just couldn't remember it, and then they gave me a stack of papers, and then I couldn't figure out, well, he's not really 6 months, he's more like, and what does this really have to do with me? And so if I've had that experience as a healthcare provider, for me, the one thing would be for women to recognize that it takes a village, and that whatever provider you choose, that provider is insufficient. Sorry, it takes my mother, my sister, my next door neighbor, perhaps a social worker, absolutely a lactation consultant, somebody who can inform about stress management and mindfulness. It takes that to have not a stress-free, because life happens, right? What we need to know is to figure out how to navigate and who needs to navigate it with us. And that's what I want for everybody.
Venus?
Piggy? Kind of a combination of the two, where I think that diversity is key, and like you said, just not because, but in spite of, right? So, and not necessarily more, yes, we need more Black physicians, absolutely, but we also need more Black certified nurse midwives. We need more Black nurse practitioners. Because there's not enough Black physicians, we need those other sectors as well to be able to fill in the gaps. And that will kind of bridge that gap between the missing and what we have in the missing.
Thank you. Melissa?
I feel like events like this is exactly what we need. We need more time together. I love hearing from everyone from different backgrounds. We need more time on this subject with the community. I think that'll be a major, it'll be a major part of improving the maternal death rate. So not only just shining light on this subject, I think a lot of America has started to shine light on this subject, but also take action.
Thank you.
I would say, if we could change the provider's ability to listen to understand instead of listening to respond. You guys say that you get this limited amount of time, this 7 minutes time frame, and during that 7 minutes, I think that the birthing person explains how they feel and things that might be wrong with them, but the physicians don't hear that. They don't listen to understand, and I think that if they did, a lot of things could be combated before it ends up being fatality.
Education, a lot more education. Thank you. Ty?
I would probably say my wish is probably advocacy to be seen and heard. So a lot of times we do come in with these preconceived ideas, notions, thoughts, preferences, but sometimes we just have to meet people where they are. And just kind of see what they need and how we can provide them and just meet them where they are. So my wish is that people will be advocates for themselves and learn how to be advocates for themselves and not have this fear that they're not going to be heard or not be seen.
Thank you, Tiffany.
My wish is that mental health is no longer left out of the conversation when we talk about maternal health, because they are like intertwined and we can't have one without the other. A part of that too is for us to have the language to really identify and describe what's going on, because with that, we can remove the shame and guilt that really like plagues our community in not getting the help and treatment that is available, right? Like perinatal mood and anxiety disorders are preventable and being treatable. But if we're not talking about it and we're not giving our families and communities the language to talk about it, then it's just like nothing. Like there's no way for us to identify and work through it because it's just like this cloud that's hanging over our heads because nobody's really saying the things and what they are, and that's preventing people from getting the help that they need.
Thank you, Whitney.
I think for my wish list is to learn more from the living. I think hearing Janisha's story, there are a lot of women that experience the same story as her that are not here with us today. And we do so much learning from those women that have passed. And we need to do more learning from those that are still here with us and have that story to share to make change. And I think hearing Venus talk about the funding that sometimes it takes to make change, those women don't get that. So I know Black maternal health is a trendy topic right now, but there's a lot of women doing that groundwork, providers, men and women, doing that groundwork in our communities, and there's no funding and investment in it. We have these events and there's talk about it, but my wish list is that there's more funding and investment in these community programs that are actually doing the work so women can have a doula to go with them to appointments, so someone can have, someone to advocate for them, because that groundwork that's there, those providers are needed, but there's often not critical investment in that. So my wish list is to learn from the living and investment and funding.
Thank you so much for that, everybody. One of the wishes was that we have more programs like this, and I'm going to tell you about part 2 of our program here shortly. But first, I want to honor our panel this evening, and I hope you all will join me in a round of applause. What a great, stimulating, and robust speech. Thank you for that. I want to thank all of our esteemed panelists again, and for those of you that joined us on Facebook and here live with us on such an important topic. We have endeavored to shed light on some of the issues concerning Black maternal mortality this evening and the continuum of care, and we appreciate your time and attention to this important matter. I do want to say that we'll make every effort to get the video recording available through the Reimagining America Project YouTube channel and Facebook, and tonight's PowerPoint slides will be made available to the website as well. At this time, I want to dedicate tonight's program to raising awareness about the National Maternal Health Awareness Day, which is next Tuesday, January 24th, where access to care is this year's theme. Access to mental health care is increasingly becoming unobtainable for many patients in the United States, even in spite of expansion of Medicaid in the state of North Carolina. Ongoing financial, staffing policy changes have forced hospital administrators in both rural and urban communities to shutter their labor and delivery units. Some of them are shutting in some of the smaller areas, smaller towns. This causes patients to travel much longer distances to receive the care that they need. In particular, rural access to maternal care grows ever more challenging. More than 1/3 of U.S. counties consider maternal care deserts, according to the 2022 March of Dimes statistics. Many people, including those in the postpartum period, are also losing Medicaid coverage following the end of the COVID-19 public health emergency. And so now 12 months immediately after delivery can be the critical time when care is needed the most for some of these families. Many of those living with maternal mental health conditions must also have continuous access to care, as they are facing systemic challenges in accessing the treatment that they need as well. So we've covered the continuum of health care from prenatal care, intrapartum care, and postpartum care, and on through the life of that newborn through its first year of life, which is expressed as infant mortality, one of the worst in the country and in advanced countries. There are resources that will be shown on the slide, if you will, I hope, where you can get more information. And yes, I want to make sure that your voice is heard. Also, as we navigate forward, we'll look to promote our next event. Finally, please plan to join us. That'll be 2 weeks, June the 30th, as we look at advocacy. Oh, yes, 2 weeks, January the 30th. As we look to approach discussing advocacy, legislation, the role of the federal, state, and national agencies addressing the disparate care for African American women and the outcomes. Our title for that event will be Taking Action, Public Health Policy and Legislation. Again, that'll be January the 30th at 6 p.m. here. We'll focus, and that focus again will be on policy and procedures that we can legislate to advance the cause. Attendees can expect to come away with valuable information to enable their own grassroots advocacy on identified key policies and legislation. With that, I think, again, I want to pay homage to our esteemed panelists this evening. One more round of applause for them. I think that concludes the business for this evening, and I bid you all good health and good night. Thank you.
Thank you all for your great attention, and thank you again to the panel. Dr. Robinson and I are just so pleased that we had such a great presentation. We also want to recognize at this time, as we close out our program, the 3 collaborating organizations who really supported our efforts all along and have helped get the word out for folks to take in these programs. They are the League of Women Voters of Charlotte Mecklenburg, the Coalition for Truth and Reconciliation here in Charlotte, and the Healthcare Justice North Carolina organization, which also is based here in Charlotte. We have wonderful partnerships with members. We are pleased to have representatives from each of those organizations here this evening. And once again, thank you. Please, be aware that our next program on January 30th will again be supported by these 3 collaborating organizations. So everyone, thanks again. Good night.